So maybe just start out with, one-on-one. When patients are referred to you, obviously at a coronary referral center, never having seen a TURBT. If the imaging that they're coming in with is fairly consistent with the bladder tumor, do you still perform office cystoscopy or are you going straight to the operating room typically?
Yeah, it's a great question, Aditya. I think if it's convincing enough, I try to make it easier for the patient and skip that part. We know that almost all tumors in the bladder are malignant. Whatever it is, we're going to have to take a biopsy or do a TURBT. The only caveat is when there is potential ureteral involvement or hydronephrosis, and there are considerations for putting a stent in. You might want to know that preoperatively just for logistic purposes. Otherwise, if that's not an issue, then you can take the patient directly to the OR and sort of skip that.
Yeah. So stents versus PCNs, if patients are coming in with, bulky tumors, do you have a preference here?
Yes, I do, and I prefer to put in PCNs because there's some evidence that the upper tract recurrence rates are slightly higher when you put in stents. I don't think that's been corroborated with multiple studies, but at least a few showing higher upper tract recurrences. Also, it gives you the chance to really resect as much of the tumor in the bladder as possible, not having to worry about the renal orifice and making sure you're going to be able to find it to stent it. So yeah, I prefer it if possible.
Yeah, I think that's exactly how I feel. I feel like there's emerging literature very similar, like stents after ureteroscopic biopsies and so forth for upper tract cancer that suggest, higher rates of recurrence when you essentially open up that typically one-way valve. Are you starting to use MRIs of the bladder at all in your practice?
Actually, interesting you mentioned that. I did a study a long time ago using MRIs, sort of dynamic contrast enhanced MRIs for bladder. I did about 137 of them consecutively. And in some instances, it is helpful, but our study did not show it's any better than CT in discerning the sort of stage difference between a T2 and a T3. It's helpful, I think, when you have prior radiation or you can't use contrast, IV contrast, and CT scans. Where there's question of seminal vesicle involvement or prosthetic involvement. MRI does have a better sort of tissue delineation there. But otherwise, trying to differentiate between a T2 and a T3, I don't think it offers any additional information. The other issue is that I don't know if you've ever heard of that patient, but having done many of them, this takes a long time. It's also the protocols used for bladder are very different, and they have to have the radiologists have some expertise in doing bladder MRIs. These are not sort of your typical CT urograms that everyone's familiar with. So I think there's some nuances. I'm not sure it's worth the extra effort and potential cost, and also patient discomfort, as these things can take up to 45 minutes sometimes to acquire.